Hello, my name is Cristina Voinea, and alongside my colleagues Constantin, Vica, and Alexandru Dragomir, today we're going to talk about therapeutic relations in the age of AI. Medicine and technology have always proven to be good traveling companions. While medicine offered the goals, technology offered the means. Technological artifacts were often used in order to enhance, to improve, or to render more efficient patient care and management. Artificial intelligence systems used in clinical settings are just the latest development in this tight relation between medicine and technology. But unlike previous technological artifacts whose main role was just to mediate or to enhance physician senses and physical capacities, current AI systems have a completely different purpose. Their aim is to increase or at least to improve physicians' reasoning and decision-making capacities, and this is why they are used especially in diagnosis and treatment recommendations. As such, AI systems are important moral proxies in doctor-patient relationships with the potential to assist or to guide doctors in their reasoning, but also able to make their own decision concerning the treatment and care of patients. So what we explore today in our talk is how the introduction of AI systems in medical practice alters doctor-patient therapeutic relationships. Our thesis is that although current medical AI systems increase effectiveness in diagnosis and treatment, they nonetheless have the potential to introduce another layer of paternalism in these therapeutic relations, which we call technological paternalism. The practical implication would be, of course, that medical AI systems should be designed so as to foster patient-centered therapeutic relations. The roles doctor and patient play in clinical settings have been conceptualized differently across various historical and cultural settings. Having in view how power dynamics shape doctor-patient relationships, three models were put forth in the bioethics literature. The first one, the activity-passivity model, was specific to emergency settings and places the doctor completely in charge while the patient is fully dependent on the doctor's expert knowledge. The second model of guidance cooperation places the doctor in a position of power due to his knowledge, while the patient is expected to comply with whatever treatment recommended. The last model of mutual participation is premised on the postulate of equality. More specifically, doctors and patients must start from approximately equal positions of power, and they must work together in order to reach the best treatment option. So the first two models, the activity passivity and the guidance cooperation models, were deeply paternalistic towards patients, and they have been replaced by the ethos of patient-centered medicine, which is based on patient autonomy and right to self-determination. So this development is due in large part to the wide critique of paternalism in clinical settings, which brought forth the need to democratize decision-making and to empower patients. So patient-centered medicine is premised on two ideals. First and foremost, patients should be treated as individuals whose values, whose preferences, whose beliefs, and social context shape their health. So this ideal is in turn based on the fact that medical decisions involve not just clinical information, but also values and preferences. Consequently, if the therapeutic process is value-laden, then doctors should treat patients as partners in decision-making processes, as treatment should also be shaped by the patient's values. So although there are various models put forth for bringing into practice this approach, they all emphasize the fact that communication, explanation, and exchange of information become the central elements of the practitioner-patient relationship. Shared decision-making between doctors and patients in clinical settings shift the focus away from a mechanistic understanding of disease towards a more biopsychosocial perspective of the individual as a whole. So because more information is exchanged within this paradigm than in the previous therapeutic relations, where the patient was simply expected to comply with the physician's guidance, the patients can now supposedly reach a decision about how to continue treatment processes on informed grounds, which is supposed to guarantee the autonomy of patients. So our purpose is to see how medical AI affects, firstly, physicians' propensity to take values and preferences into consideration, and secondly, how they affect information fluxes between physicians and patients, because these are the two levels that must be taken into account in order to accomplish a patient-centered therapeutic process. So first and foremost, medical decisions involve not just clinical information, but also values and preferences. For example, given certain circumstances, some may put more value into the quality of their lives, while others might prefer adding more years to their lives, regardless of the quality of these years. So as such, when AI systems are used, it's not just the patient's values which drive the ranking of the treatment options, but also some generic values embedded within AIs. This means that the patient's values are contrasted and discussed only as a secondary alternative to an already offered list of potential treatments. And the situation might be even worse from an ethical point of view when AI systems would make a single recommendation. So the main hazard we see here is that physicians might overly rely on the resolution and counsel of AIs, which can reduce patients' role in decision-making processes regarding their own healthcare. Coupled with this problem is the additional issue generated by the fact that technologies and medical AIs as well direct physicians' attention away from the patients and towards the device. Because technologies offer objective measurements and knowledge, the patient's subjective experience tends to be overlooked. And this has the potential to remove even more the patient from the therapeutic processes. But this largely depends on the physician and on whether they take into consideration the patient as a whole and not just as a bundle of diseases. So on this level, we claim that AI systems can contribute to returning to a mechanistic view of disease and of patients only when there is already a predisposition of physicians to do so, mainly to ignore the social psychological situation of patients. But before seeing how AI systems impact information fluxes between physicians and patients, we should try to characterize or to stress some of the characteristics of current AI systems that might have a say in how information is transmitted between doctors and physicians. And of course, one issue with AI in general and with medical AI in particular is the issue of explainability. A system explainability can be defined in terms of a certain ability, that of offering reasons for its outputs and overall behavior. Once such reasons are provided, it is reasonable for us to trust the outputs of a non-transparent black box algorithm. But here, the problem lies in the tension underlying what traits a good explanation requires, and a good explanation requires interpretability and completeness. What we aim in designing interpretable systems is, simply put, understandable behavior on the part of the system, while complete explanations are aimed at better predicting the behavior and outputs of the system. So since interpretability is tied to our intuitive and common abilities to understand and completeness on gathering expert knowledge on the mathematical inner workings of a system, any increase in one presupposes a decrease in the other. We may understand in a truncated or incomplete manner the behavior, or we may be able to have a good mathematical knowledge of the inner workings of the system that offers the patients and medical staff no insight into how the output was obtained. And this gives birth to a dilemma, we claim. It seems that we have to choose between accepting that we should not fully trust the incomprehensible yet highly accurate behavior and outputs of an AI system, and accepting that such trust implies decreased autonomy on part of both patient and medical staff. So recall that communication, explanation, and exchange of information are the cornerstones of patient-centered medicine. The algorithms underlying medical AIs, especially deep learning algorithms, are essentially black boxes, meaning that they are inscrutable both to practitioners and to patients. So if doctors do not know how the medical AI reached a certain output, this also means that they cannot explain to patients the reasoning used to reach the proposed diagnosis and treatment. And as it has been discussed in the bioethics literature, good informing is different from merely providing information. Good informing presupposes taking into considerations the patient's epistemic limitations and offering information so as to help patients understand the significance of what is mentioned. The idea here is that less information and reduced explainability prevents patients from acting autonomously. But this opacity of medical AI systems also impact the epistemic obligations doctors have. If AI systems are better than humans, then physicians have the epistemic obligation to follow their recommendations. But physicians also have epistemic obligations towards their patients. For example, a physician has the obligation to inform patients regarding the risks of certain treatments or medical procedures. So if doctors are bound by the epistemic obligations they have to rely on artificial intelligence systems, when the latter are, of course, more knowledgeable, more efficient, or even more accurate in decision making, this generates a conflict between obligations. Because when physicians rely on AIs, they are unable to fulfill their epistemic obligations towards their patients, meaning they are unable to explain to their patients how the certain decision was reached. So this gives rise to what we called a soft technological paternalism, both towards physicians and towards patients. When a doctor using AI takes a decision based on a recommendation made by the AI and is not able to explain why she takes or took that decision, this is a problem for two reasons for our patient-centered approach. First, physicians fail to act as responsible agents for what they do because they actually don't know what they are doing, because the AI is unable to offer explanations to physicians. And secondly, the physician also fails to act responsibly towards the patients affected by the action or by the decision, because they cannot offer their patients the explanations for how a certain decision was reached. So black box AIs in clinical settings are paternalistic both towards patients and towards physicians. Thank you so much for your attention. I hope you enjoyed our lecture.